I'm Richelle Koopman, as John said. I have a master's in clinical research, but my ARC-K award allowed me to get some additional training in human-computer interaction, human information behavior, and even to come up here and take the systems engineering SEEPS course. So I know enough about human factors to be dangerous. Luckily, my frequent collaborator, Jeff Belden, also likes to run with scissors, so we get along quite well.
Yes.
Yeah.
And so I'm Jeff Belden, and I did 25 years of private practice in Columbia and a little bit of teaching half day a week on the side. And then about 7 years ago, came to the university to be half doctor, half geek, and to focus on evangelizing EHR usability. So we'll talk more about that in a minute.
All right. So we do not have any conflicts to declare. We would like to thank ARC for supporting especially the work at the end of the presentation, and also the California Healthcare Foundation and SHARP-C, part of the Office of the National Coordinator for Health IT, that supported inspiredehrs.org, which is what John was talking about, which is our ebook. So the objectives today are to demonstrate human factors principles at work at EHR design and examine the influence of the physical environment on the work of primary care office visits, and forecast future trends in EHR design. So to design EHR tools, we need to understand information needs, we need to understand tasks, the context, and then we have to understand design to make the information clearer and design to aid in decision making. So if you're a doc in this room, raise your hand if you ever use one of these. Yes, this is a paper chart, and we've come a long way from there. In fact, the first EHRs were standalone in your office or hospital, and then it was a real boon to be able to get labs and then to be able to get discharge summaries from the hospital. And we've seen this evolve over time. And then you're able to see ER and consultant reports, and then you're able to e-prescribe, and now the patient can log in, and finally health information exchange. And then things get more dynamic as we're moving forward too. But back to...
Bumpy along the way.
Yeah, it was bumpy along the way, yes. Back to the paper chart. For those of you who are not familiar with the paper chart, on the left side, there would be the problem list of the patient and the medication list usually. If they were on warfarin, there might be a running log of doses and INRs, which we called PT back in the day. Yes, the lab test. And then, but on the right were all these tabs. And you'd have your progress notes usually on top, and then each tab would have the radiology part, the labs, consent forms and other documents, maybe outside documents. Other things would be under each one of those tabs. And so when the first EHRs came out, they tried to mimic the paper chart. And so there would be tab dividers. This is a really old Cerner picture. It doesn't look like this anymore.
No.
Yeah. No. So there are tabs along the top, and just like the old paper record. I realize that this is an old slide and it doesn't look like that anymore. So in order to find, oh, you made it worse.
Yeah.
Don't touch it.
I got close to the machine. It's like in the old days, if you got close to the TV antenna in your house, it would like make the signal go.
Anyway, so in order to gather information for a patient visit, and we're going to say this is a patient visit with diabetes, you would have to go here and look at the problem list. And then you would want to look at their medication profile, so that's a different screen. And then you'd want to see what are their recent lab values, maybe what's their A1C, and so that's a different tab. And then if there's a recent radiology report, you need to go to a different tab and open that up. And then if you actually want to see their vital signs, that's a different tab. And then maybe you want to look at your last progress note, or this is actually discharge summary from the hospital. And the thing is that while you're doing that, you have to keep all of that in your working memory. All the information that you've gathered, you're storing, and you're using all your mental energy to store the information, and so you don't have any mental energy left to process the information. And so you're just holding that in your head until you get to where you need to be.
And it turns out your working memory really only holds about 3 or 4 pieces of information.
Right. It can hold 7 plus or minus 2, but this is complex information, right. And so it holds a lot less. Absolutely. And that creates a lot of cognitive load. And this is what cognitive load looks like in fantasy. And in reality, it looks like this. And on the left, here's what it looks like when you're alone. And on the right is what it looks like when you're with a patient. Now, this guy actually has a paper chart, so that's interesting. But what's happening is he's digging through the chart just like you would be digging through your electronic chart. And the patient's sitting there going, what's he doing? What's he looking at? And you're just trying to process the information. And what he's looking at is this, which is, this is an just unconscionably littered note for a strep throat. And that's not even all of it.
Noisy and way too long.
Yeah, there's so much non-essential processing that you have to do to read this note. And really all you need to know is that the person had a sore throat for 2 days and you prescribed penicillin because they had strep. And maybe that their tonsils were big and white and bad smelling. And so this creates a lot of extraneous processing as well.
And early on, that's how our colleagues at the university review the information. They dump it in a note because it would auto-populate, and then they'd read inside the note for review.
Right, exactly. Yeah, all the stuff is inside the note. So we got together with our colleagues and designed a one-screen view of all the things you would like to know about patients with diabetes. And the problems are on the left, the allergies, the home medications, and then all the events that you would want to know about, like blood pressure, their smoking history, their labs, eye exam, foot exam, whether they're on an antiplatelet drug, their cholesterol. It's all on one thing. And this first column is the most recent value, and the second column is the value before that. And then there's those little sparkline graphs that show the trend over there. So this was...
Not all labs, it's the ones that sort of pertain to diabetes.
Exactly. And then if you zoom out, you can also tell people what to do with this information. So all of a sudden you put these performance measures at the bottom, and now you've focused people's attention on getting rid of those red dots. In doing this, you're definitely giving them a nudge. You're saying, this is what's important for you to do. And so the tool is now going to be shaping the task. And so you'd better make sure that that is really what you want people to do, because they're going to be doing that instead of anything else, because they don't have that much time. But that was part of our dashboard as well. And we did some usability testing on the dashboard, and we found that it saved them over 4 minutes and 50 clicks and increased accuracy in finding needed diabetes information. And then in our qualitative data, when we gave them this dashboard, they were like, you know you got it right. We're like, the CMIO for our organization said this was the best thing to come out in the 8 years of using our EHR. And Cerner said they started counting click counts after this because we had saved 50 clicks. And when we...
60 down to like 6-ish.
Right. And when we were doing the usability testing, that was the first time they had ever seen it. And one of the docs said, can we get this tomorrow? Like, I need this right now. I also wanted to talk about satisficing, which is, if you're not familiar with that word, that's a combination of satisfying and sufficing. And satisficing is when you settle for minimally good information when you're searching. And a lot of our doctors said that they would satisfice before the dashboard. If they couldn't find the needed piece of information, they would ask the patient, when do you think your last eye exam was? Because they're digging through the record and they're taking lots of time and they just can't find it. And so they satisfy that need by accepting a less reasonable quality of information. Like, oh, I think my eye exam was 14 months ago. And then what happened to our wonderful dashboard is it was not interactive, and so we needed an interactive dashboard, and so our lovely EMR vendor listened to its users, and the users told them what they needed. And so now we're back to the workflow where you have to go find the vital signs, go find the problem list, go find the home meds, and go find the labs. Our dashboard now is interactive, but it's not all on one screen, and it has all kinds of junk on it. It has a lot of Chrome. It has scrolls within the page. It's just not good. And this other dashboard that we created has been left to decay, and it's finally been discontinued, much to the unhappiness of all of our docs. So we're kind of back at the beginning on this. Oh, you have an animation in here. Go ahead.
Yeah. And it's a more complicated story about how the dashboard died, so we won't inflict that on you.
It's a sad story.
It's a sad story, yes. Just to review, I mentioned I'm a usability evangelist. I'm a self-proclaimed usability evangelist, and so my mission is to really help provide empathy for the users, and that may be doctors or nurses or other clinicians or patients. And I stated as my mission is to relieve physician suffering by improving the usability of the software they use. Now, Christine Sinsky, is she here yet? She's coming. She'll be here tomorrow. But she's been promoting the idea of the joy of practice for physicians, and so I kind of reworded it to say, well, to bring physicians joy by making their software delightful to use, but it doesn't have the same emotional impact as suffering. So when I tell my physician colleagues relieve suffering, they say, oh yeah, got it. When I tell them we're going to bring you joy by making the software better, they say, yeah, right, we'll see. So I'm sticking with suffering for now. So our organization had developed a collaboration with our software vendor, which we've mentioned as Cerner, and we had some good stuff together, but after a while it felt like our designs and expression of what we needed were not getting through always. And meaningful use took lots of oxygen out of the room. So we thought, well, how else can we express these ideas and get them out into the world and see what's dumb and what's not? Because we told Cerner a lot of dumb ideas too. So anyway, we got funding to do, we got funding to do Inspired EHR's designing for clinicians, and the target audience was health IT vendors, and the idea was it's free, it's online, it's sponsored by two public organizations, and we wanted to provide inspiration and clinical perspective to the ideas we had. So it started with an idea about, let's just do this book about the medication list. But in order to get funding, actually it's more like a dozen medication lists. So the varieties of medication lists that might exist in our world are, on the left-hand side, provider reviews that vary from the simple list at the top to way more complex lists as you go down, like medication reconciliation. So if somebody's in the hospital, they have their home medicines, then they get admitted to the ER, then they get sent to ICU, and they go down to the floor where things are easier. Then they go back to ICU when they get sick again. Their medicine lists change all the time, and it's easy for the medications when they go home to be screwed up. So the medication reconciliation tool is, what did they have before? What did they need to go on when they go home? How do we get a safe, coherent list? The patient views might be as simple as it's the little piece of paper that the man has in his pocket or the woman has in her purse with the names of the drugs and maybe not even the doses, to the more complicated things where the remote caregiver or the adult child who comes in once a week to fill mom's medicine minder with 20 different medicines and 4 times a day dosing, that's the complicated list 9 at the bottom there. So which medication list is the one that the user needs? Well, it depends on who the user is and what's the task at hand. So if all you're doing is reading a medication list inside a progress note, it can be a pretty simple list. So actually, the blurriness doesn't really matter that much. This is the note as it appears in our EHR a couple years ago, where there's a lot of information, half of it's unnecessary, and it makes it very difficult to just read the note to know what somebody's on. So our little makeover redesign makes the medicine most emphasis by making it black and bold, and then the dose of important but secondary importance is a little lighter, and then the instructions are even lighter. So as a physician wants to know, are you on lisinopril for high blood pressure and heart failure? I can scan the list and look to the letter L, and the answer is, oh yeah. Are you on insulin? Yes. So if I want to know the details, I can look just a little longer. So that's an example of a makeover. So another medication list might be for managing medication renewals. I need more information. How many tablets, how many refills, when will you need your next refills, et cetera. So in our EHR, this is kind of the view, and the red lines tell you what my eye has to do to track through the details. So on the far left are the blue medication names and strengths. In the middle, where the red lines are, that's where the instructions and the number of refills and the quantities are. But it takes a lot of mental effort to scan back and forth and read and multiply and think. And that's just too hard. Even if I sort the columns, the next two columns are the most recent changes in the list. I could sort and put old stuff at the top. That's likely what needs to be refilled. But still, I have to do math. And once in a while, somebody accidentally puts in 0 refills, and it's hard to notice. And a simple redesign would just be doing something like the battery fill indicators on the far right. So how much juice is left in this prescription? And if it's full, you're good for the next 12 months. And if it's running low, actually the colors change when you get lower and lower number of refills left. So that just is So that takes advantage of the pre-attentive attributes that the visual cortex and visual centers of the brain can do. At a glance, I don't even have to, it's before I can think, the refill icons can tell me what needs attention. So the challenge is, why can't clinicians get what they want? Because you can get doctors in a room and have them tell you what they want, but they're not necessarily getting what they want, and the answers are complex. And they also want it now. So it's important to think about the concepts of design thinking. So Richelle's a researcher brain, and I'm kind of a designer brain. And in design thinking, we think of 3 overlapping spheres. So one sphere is what's desirable, and that's what clinicians can articulate. And another thing is what's feasible, and that's what engineers can tend to say, hey, we have this new set of tools, we can do data visualization, we can do predictive analytics, where can we try this? And so you look for the overlaps. So that's part of what our group here today gets a chance to, over the next day and a half, gets a chance to play with. But the third thing that matters is what's viable in a business sense, and that's what the vendors have to struggle with. So the areas of overlap are that. So you can see that clinicians have a lot of ideas that they want, and some they won't be able to get because it's either not feasible or it's not going to make business sense. So to do the book, Inspired EHRs, our challenges were getting funding and setting the scope. So my original idea was we can do an entire book on the medication list because there's a lot to say. But to get funding, we needed to get they asked for 8 chapters. We settled on 5 chapters on different topics. And so then we put the team together, which was our community of vendors, worked through the EHRA and the Clinician Experience Work Group. So that was a key component. We had human factors experts that we recruited from around the country. We had design team in Boston. They were the expensive part, but they sold their services at cost. And then we had our clinicians, physicians and nurses and pharmacists. So, and then the idea of the book, it wasn't automatic that it would be useful to the target audience. So we needed partly to make sure we understood their needs, and that's why we engaged them early on. But we also needed to make sure that how we promoted it was appropriate. So our original title was something like Style Guide. Well, so I kept saying, look, this isn't prescriptive. You're afraid it's prescriptive. It's not. It's just inspirational. It won't be a requirement. But you could still tell that the room was nervous. So what really made a difference was the title, changing the name. So originally, we called it Style Guide, EHR Usability Style Guide. And the vendors kept telling us, no, that's a prescriptive thing. And we kept saying, no, it's not going to be prescriptive. And so it turns out that in the design discipline, style guide is prescriptive. Here's how we're going to do it. So we, at our last workshop with the vendor teams, we came up with a better name that we think is inspired, and it's Inspired EHRs Designing for Clinicians. So the clinician part is in there. It makes, our contribution was uniquely valuable because other guidelines out there were sort of human factors and research oriented and didn't necessarily articulate the clinician's perspective and help the vendor teams empathize with the users. So that has turned out to be more successful. Here's what the landing page looks like if you go to the site on the web. Here's what the chapters are: med list, med rec, allergy list, e-prescribing, and drug alerts, and then some chapters on the underlying science of human factors and design principles. So a quick peek inside. We include clinical scenarios in line in the chapter to help the reader think, when are doctors and nurses going to use this? And then we include images, examples. I showed you the makeover before and after. And then we include links to human factors principles. So within the chapter, there might be a brief thing on working memory. And so for most readers, that may be plenty. But for some team members on the vendor community, they may want to dig deeper. So they can click on the little blue link there, and it'll jump them out to the entire chapter on working memory in the human factors part of the book, and they can read more. And these chapters include visual examples, which we think are important. So this is the general example of symmetry principle, but we also include EHR-specific principles. So this is symmetry as demonstrated in a health IT application. And so we're going to show you a couple of the prototype components inside the book. So we thought prototype components were going to be necessary because that allows the reader to play with it and mess around and let the concept sink in deeper. And also we hoped that they would inspire. I remember for the medication timeline, we'll talk about that in a second. Inspiration can be helpful. Yeah, so there is code here. So if somebody wants to, go to GitHub and get the code and play around with it, they can do that. So Twinlist is a prototype made at the University of Maryland several years ago, and it basically takes these medication lists and then helps the user combine them and present the data in a really simple way. So what I'd like to do is play the video. So let's see how that works. Yeah, if you can go to YouTube and you can just Google Twinlist. So what's happening is you started with two lists, the one on the left and the one on the right, that were the home list and the hospital list. And then it animated and sort of did a lot of matching. If you weren't watching, we'll just reload the page and watch it. Oops. Again. So two lists, identical things match in the middle. Different things go way out to the side because they're so different. And things that are kind of similar but might or might not be a match are lined up in these intermediate columns. So in the second and next to last column, the beautiful thing about this is it's already started to reduce the cognitive load of the user by highlighting the things that are different, which you can't quite see in the room. So that helps to reduce a lot of the load that the physician would otherwise have to do. So I just want that. There we go. So medication timeline. The other prototype that we built was the medication timeline because it's so hard to figure things out without one. So the question is, physicians and patients often have the question about story of the medication. So when did you start that medicine? Why or when did we stop it? Why did we change that dose then? Why aren't you taking what I think you should be taking? Sometimes I'll look at a medicine list and I'm thinking, lisenapril's missing here. Why aren't they on that drug? Because usually I would prescribe that drug in this situation. And the answers can be so hard to find because it involves looking through multiple pages or reading long lists. So we played with another timeline, and I have many sketches of bad timeline ideas that just were not working to show the dose and multiple daily dosing. And Yeah, you can see a little bit better. So over here, these multiple lines are once a day, 3 times a day. That doesn't scale when you add a bunch of medicines. So then
He's always drawing. He
yeah,
draws on envelopes, he draws on whiteboards, he draws on his computer.
her forearm sometimes.
Hey.
So I saw this flight search engine, HipMonk, and I thought, oh my God, that gives me an idea. So HipMonk, we'll show you that later. HipMonk helped me see how timelines could be displayed more concisely. So this is our little prototype of the medication timeline, and that'll show a lot of medications on a single view without scrolling. That's maybe 20 or more medicines right there, which I often need with my chronic, complex, older patients. Black is, and here's the tutorial you need. Black is the maximum dose, gray is less, lighter is lower, new stuff is on the right. Once I tell you that, then you can figure it out. In fact, we just did focus groups with our patients on a simplified model of this, and they just figured it out with like no introduction.
We didn't even tell them that.
Yeah. The other thing is that this one's sort of like an overloaded timeline, but if I take a simpler timeline and just build in a story, like here's what happened with their blood pressure, and here's their sleeping medicines, and here's when they got anxiety, and here's where we're going to change the dose. If I build that and I just show it to a doctor, they can tell the entire story just by looking at the timeline. And sometimes they'll come to a part where it could be A or B, but still they're down to the essentials. If we zoom in along the bottom, you can change the time scale, and the red here just represents a supramaximal dose. And those recommended doses can change over the years. So the FDA came out with a little warning and said you better lower your doses. So people did.
We want to talk a little bit about technology in the exam room and the physical environment. So raise your hand if you've seen this picture. Yeah, I love this picture. This appeared in JAMA. And this was given to a pediatrician. If you're a pediatrician or you take care of children, they will bring you pictures. And is a lovely picture of the child sitting on the exam table. And here's her sister with a book, which is nice, and mom has a baby in her hand. And here's the doctor, who was horrified to see this beautiful picture, and he is back to the patient, and he's typing on the keyboard. This does represent what we worry about when thinking about technology in our exam rooms. I am fortunate to practice in a different type of exam room. Now, this is a typical exam room in our system. It's not where I practice. And I'll be sitting there with my laptop, and the patient's sitting in the green chair across from me, and the patient cannot see what I'm doing, but I have a nice line of sight across the top of my computer that I can see the patient very well. This is my practice. We have these giant screens on the exam room wall. That's not a patient, that's actually my husband. He's another physician there. And that's not showing very well. This is a very large exam room that has a consultation area and a separate exam area. And we immediately noticed when we started practicing here in 2008 that it was real different, because people were like, I'm not on that medicine anymore. And they're looking at what you're doing. And then you can show them things. And what I'm doing here is I'm showing a picture of the eustachian tube, which if you're going to talk about the eustachian tube, a picture is definitely worth 1,000 words. And it does really well to explain why someone has ear pain, but they don't have an infection. So we wanted to see what was the effect of this type of exam room setup versus the other exam room setup. And we video recorded 60 patient visits for chronic care follow-up visits in 2 practices with 5 patient visits each for 12 docs. And then we coded the videos for physician and patient gaze and a bunch of other stuff too. This picture to the right is actually not a setup. My research assistant was in the room with a patient, and the patient goes, "That's funny, did you put that magazine there?" The popular mechanic says, "Who's spying on you?" And you know she's an awesome research assistant because she snapped a picture of it. So that actually happened in one of our exam rooms, and it was really funny. Compared to the laptop rooms, the collaborative viewing of the screen was 1.6 minutes as opposed to 0.6 minutes. And the physician alone viewing the screen was almost half in the 30-inch screen room. So people were inviting the patient to view the screen more. And that's an example of, human factors principle, that the form will influence how you use it suggests sharing the information, and so people do, even though the total visit time was the same. And then we did another simplified measure, which was the patient invited to view the screen? And that happened in almost twice as many visits in the 30-inch screen room. So the physical design of the exam room itself changed the behavior of the patients and clinicians that were working in them. We also figured out why one of our providers was having neck pain. She thought it was stress, and it's because her setup is backwards. If your patient is sitting to the right, you have to do one of these to look at them. And if your patient is sitting to the left, you get this more natural open posture. And all of her rooms look like this. And she's, oh, that's why. And so we didn't get to change her rooms, but at least she knows why. And that's my ACE research assistant who took the picture. So the other thing that we noticed, and this is one of our videos, so we use Marray software, and I just blew up the picture here. And because I'm not trained, my home training is not in this discipline, I use Marray in ways that it was never meant to be used to record exam room visits. And I'm going to show you this visit. This is my patient, and that's actually me. And in about a minute in, it's too bad we don't have sound. Yeah. Yeah, that's fine. So she's saying she went to the ER with chest pain, and I'm really keyed in because I looked at her blood pressure before I went in, and all of them are like 140 and 150 and 150 over 90 something. And my patient doesn't have high blood pressure. I'm like, what's going on? And so you see me here, I'm checking them because I'm getting ready to graph them because I'm like, I don't know what's going on. She doesn't have high blood pressure, but all her blood pressures are high. She went to the ER for chest pain. Is it possible that she developed high blood pressure? Did something happen? And then I'm saying, oh, did they get you a stress test? No, they didn't get a stress test. And what you can't see, because this actually is blurred, that's why you can't see it for her protection. She's wearing sunglasses because she's having a migraine on the day of our visit, in addition to having been to the ER for chest pain like 2 weeks before. And so I'm itching to get to the screen, and there I go. And what happens right here is I go, oh! And what's wonderful here, that's my O right there, is because I put up this graph. And what the graph, what the graph told me, come on, baby. Make it go for it. What the graph told me was that her blood pressure was only high recently, which was what I was saying in my head, but I didn't realize it until I saw it, that the times when her blood pressure was high was her 2 or 3 measures that were done in the ER and the one done today when she's having acute pain of a migraine. And I knew that all in my head. She doesn't have high blood pressure. Why is her blood pressure high? But the graph is what brought it all together for me. And so that made us start thinking about using graphs in visits and what the power of a graphic display was. And the neat thing here is, since we made me one of the subjects, we have access to something that we don't in any of the other observation, which is what's going on inside my head. And so that's
I'm afraid to pause it or touch.
Yeah, I know. So that's a picture of it's only the latest ones that are high, and the rest of them are all in the red line, which is the second.
And it's not all that easy to tell if they're high in this view, because the red line is not easy to spot.
I can see the red line here, but you all can't see it up there because this is a little bit blurry. But yeah, and then I'm explaining to her about her blood pressure. And you can see here, I'm inviting her to view the screen, and we're looking at it together. Why is that important? So we looked at these visits, and where tables were viewed, they were shared with patients 38% of the time. But when graphs were viewed, which was not a large number of visits, they were shared with patients 100% of the time. So there's something about graphs that says share with the patient. Or when people want to share with the patient, they navigate to graphs. I don't know which it is, but there's something about graphs that is clearly special. And one of our patients said, it gives you more of a perspective. Numbers don't mean a whole lot, but when you can see the curvature and the form that it takes, you have a better perspective of what is going on. So this is what graphs look like in our EHR right now. And this one you can see that there's a red line going through 1, 2, 3 from the top is 140. And then there's a red line right near the baseline x-axis that is 90. And then here's the diastolic, and this is 90, and this is 60, and it's got red lines. And so you can see that the patient is in range or isn't in range and when they were high. Explain this graph.
And our vendors produced an iPad app, and so a lot of things are way better on the iPad. But this design here, this is the blood pressure graph, and it's pretty faint. But each blood pressure is represented by 2 circles connected by a line. Now, family doctors look at that and say, we never graph things that way. But anesthesiologists and critical care doctors and surgeons say, oh yeah, that's the way we do that in the OR. And a lot of the way that things happen in the paper world were because I can do that really fast on paper. Draw a line between. And that was before the days of technology. Same way with displaying labs with the fishbone diagram, so clinicians will know what I'm talking about. The rest of you may not. But this is partly an artifact of the working environment and the need for it to be fast with paper and pen.
Right, but
it
that's
doesn't work for doctors and patients very well.
Right. It works in the ICU, and that's where this should stay.
Now the gray band across there makes it nice because it's easy to say where is the normal range, but it's only one normal range.
Right. So let's talk a little bit about home blood pressures because we're working on that a lot. So these are Margaret's home blood pressures. She brought this to me, and you can see that her blood sugar is actually on the left, and the blood pressures are on the right. How many people get blood pressures brought to them like this? Does anybody get blood pressures electronically? No, you get them like this, right? Okay. All right. Someone brave. Raise your. Yep. Yeah. They put them in Excel, but then they printed it out for you. Yes. No, we get that too. So would some brave soul raise their hand and tell me what you do when you get one of these in the middle of a 15-minute chronic care visit that has 3 chronic and 1 acute problem?
I eyeball it and try to figure out what the range of systolics, 128 to 148, and then kind of a range of diastolics, and then put that in my note.
In your note, not in with the vital signs, right?
And he said, which
yeah.
implies that he's probably throwing out some weird outliers that he judges don't really fit here, but you're making judgments and summarizing in some kind of way.
To send it for scanning, and I decided that is dumb because I don't
Right.
look at it.
Right.
Yeah. So does anybody do anything different than that? No, because that's what everyone does. They get this gestalt, and they take all this data, and they kind of go, it looks like 140. This should be scary to you if you're not a physician, but it's what we all do because
the other thing is, we'll put an actual single average number. We declare this as average, and that goes in the EHR database because that's the last blood pressure, and that's what the quality measure looks at, and
Right.
that's how I get graded.
No,
I do.
no, it's not going to, you put it in with the vitals.
My nurse does it. Yeah, puts it in with the vitals.
Yeah, but most of us do what he does and put it in the note. And so nobody ever sees it anyway, so it doesn't matter.
And the frustrating thing is the science now says that we should be treating the patient based on those pressures.
That's right.
Yeah.
But unfortunately, HEDIS has not caught up with the science, and they're just looking at the ones in the office.
That's right. And the other thing is we really don't have the technology to be able to do this. And you're going to have somebody enter all these and a place to put them if you want to be able to use them. So plug for our workshop this afternoon. We're going to talk about how to incorporate home blood pressures into the clinical record. And we've been with Lindsay, who's on our team, Lindsay Steege. We've been figuring this out. In fact, here is one of our graphs, and what it is,
Version of one of our graphs.
yeah, this is actually an early version. We have the home blood pressures are the circular dots that are on the lines, and you see these orphan squares are the clinic blood pressures. And by doing that, we've declared you should be looking at the ones with the lines. And then you can see that some of our dots are hollow and some are filled. And what that is to represent is that the patient has brought their home blood pressure machine in, and we have verified that it matches, that they have a good home blood pressure machine. And so from then on, you know that it's been verified. And if it's been more than a year that you have black dots, you know that it's time to verify it again. So those are some of the solutions that we're coming up with for incorporating home blood pressure.
There's plenty of details we haven't worked out, too.
Yes. And then we added a simple medication timeline that is just the blood pressure medicine. So you can see here we have hydrochlorothiazide, lisinopril, losartan, and metoprolol. And look what we can do here. We could say, the patient was on lisinopril, and then they switched to losartan. They probably had a cough, right? That's what we would say. And then you could see.
Oh, and doctors are used to this. They've been on hydrochlorothiazide. You add a second drug. What does the patient assume? You want me to stop the other blood pressure medicine and take this new one. So
Right.
that's pretty common to have that gap in there.
Right. And then what you can see is that when metoprolol was added, and especially when it was increased to 100, that's when the blood pressure really started to come down into range. And you and the patient can digest this material and say, oh, that was really helpful. Look how important this medicine is. I know it makes you feel kind of tired, but look how important it is. Yes?
All these data points seem to be the problem, not the solution. And I mean, really what we need, it seems, is like an hemoglobin A1C for blood pressure.
Right.
And so, I mean, I think we turn our patients into neurotic people by checking their blood pressure 28 times a day, and I think this might reinforce it. And so, I don't know what the answer is, whether it's a endothelin level or something, but we need some kind of a broader term. This minute to minute to minute to minute, I mean, it's really.
The minute-to-minute variability is very troubling for patients. It is.
And that's part of our sorting. We're sorting through that, too. That's one of the next focus groups is, or one of our surveys is actually looking at how does variability affect patient perception of their control.
Ambulatory blood pressure monitoring, 24-hour home blood pressure, ambulatory blood pressure monitoring is that gold standard, but it's rarely employed.
Costs money.
Yeah. Even among our internal medicine colleagues, they said they hardly ever use it, so which was surprising to me. But the clinic blood pressures, and we'll present some of the evidence this afternoon, but the clinic blood pressures are better predictors of cardiovascular events than the, did I say that wrong? The home blood pressures are better predictors than the clinic blood pressures of cardiovascular events. So we should be using those home blood pressures more than our vaunted, we took it, clinical blood pressures. We looked at maybe doing outlier fills, these shark fins that say, oh, look, this is really high. Everyone sort of hated these. We thought they were neat. Our cognitive psychology colleagues said this is a nudge. So this says, this draws attention to outliers and says, hey, you're out of control. Do we want to make that nudge? Do we not want to make that nudge? Turned out the patients hated it. They're like, it's above the line. I can see it. I don't need the orange. The other thing, this is what Jeff was referring to. We showed this without the fills to our last focus group of patients. This is hydrochlorothiazide. This is lisinopril. You can see there's a big gap here. There's also a gap in the blood pressures. We didn't tell them anything about how to read it. And they said, it looks like this person stopped taking their medicine and their blood pressure for some reason. And so they totally got it. They saw the gap and they interpreted it correctly. And so patients and doctors can use these type of tools together to make sense of what's happened. And they said, oh, they didn't take their medicine. And then look, they came back and it was really high. And so it helps them to make those kinds of connections with their blood pressure and their medications. This is real home blood pressure data from a 3-month trial. So this is 3 months, and these patients took their home
different
blood
patients.
pressure every day. What?
Yeah, 2 different patients.
This is 2 different patients, yeah. Systolic and diastolic, and you can see this person's more in control and has less variability, that person has more variability. And we thought we would just show what real data looked like, because we had these, like, what I was showing you here is actually 4 years worth of data, and there's like 10 home blood pressures. So that's not conceptually correct, and we have to figure out a way to deal with this type of density of data over 3 months, because right now the recommendations from the AMA are that patients take it twice in the morning and twice in the evening, so that's 4 a day. And we're not going to put all those points on there. That's got to be smoothed.
Right, so we'll come up with some hemoglobin A1C like summarization of blood pressures to make it consumable.
So we believe that the future of EHR tool design incorporates several things, and one is that we want to design for a shared physician-patient experience, because the patient is a very important player in their own health care and needs to understand what's going on. And we need to be able to incorporate more patient-generated data. We still have to move from the page paradigm to data visualization and interactivity and decision support. And to do that, we will need payment regulation reform, because dumping everything like the medication list, the allergy, the problem list into every progress note when it's there on a dashboard just doesn't even make sense anymore. But that's the way you get paid, and so you have to do it. And so all that stuff has to be in every note. And everyone hates the review of systems. We have a paper about that. We did a presentation called "The Review of Systems is Junk." And everyone hates the review of systems in outpatient medicine, but you have to do it to get paid. There's all these things that we're doing to satisfy the other people who consume the record that isn't really helping the care of our patient and may be obscuring important information. Other last words?
No, and that's
Sir?
it. I think we're ready for questions. On the page paradigm, it started with the paper world, and when we moved to electronics, we brought in the tab dividers, and now it's a PDF or something like a PDF, and that's where all the stuff gets dumped so we can prove that we did our work. So we need to get to the new world of where the page isn't what we rely on. Quality reports come out of a report. Other things just come out in another report, not on the page that describes the visit.